Breast cancer is not a single disease. Today, we do not treat all breast cancers the same, so if one size doesn't fit all for treatment, why should we screen as if everyone has the same risk for the same cancer? There have been years of controversy over screening, and in the US, there are at least 7 different guidelines, and years of disagreement on how often to screen and when to start across the world is based on the same data from randomized trials generated 25 years ago. Wisdom was designed to make screening better, using a modern foundation to integrate risk assessment to direct screening and prevention, using a modern era trial to evaluate a personalized approach and hopefully to reduce the chance of finding aggressive higher stage cancers. This was an idea that sprung out of the Athena Breast Health Network, a collaboration across the 5 University of California medical centers, and we added a number of important collaborators along the way. And this was a pragmatic trial. It's women informed to screen depending on measures of risk funded by PCORI. And this, we enrolled women, participants 40 to 74 without a history of breast cancer. We offered and asked women to be randomized, but those who did not want to be randomized, who were not at equipoise, were allowed to join an observational cohort and had the opportunity to self-select their group. The comprehensive risk assessment model in Wisdom used a validated high-impact risk set of risk factors, including the model was the Breast Cancer Surveillance Consortium model, and we used germline testing in collaboration with Color Health, looking at 9 breast cancer genes, which were sequenced for pathogenic variants and single nucleotide polymorphisms to generate a polygenic risk score. And with this, we were able to tailor screening and prevention plans. This was determined the age to start and stop, the frequency, the screening modality, and what risk reduction. The risk factors were then used to assign people to 4 groups. The lowest group, which was women who had not achieved the risk of 1.3% at 5 years, was the average risk of a 50-year-old. The average risk who then got biennial screening, the elevated risk, top 2.5% of risk, and the highest risk who had the equivalent risk of a mutation carrier, 6% risk at 5 years. The highest risk got 6 months screening with alternating MR and mammo, and the elevated risk group got annual mammograms. All the pathogenic variants were in the top 2 groups, and they also had direct outreach by a breast health specialist to counsel them, as well as access to the breast health decisions tool, where they had personalized information in about their risk and recommendations for what they could do to bring their risk down. The study questions about risk-based screening was whether it was safe, whether it was less morbid, whether it would be conducive to prevention, whether it would be more accepted by women, and whether it would actually provide better value with better outcomes at lower cost to individuals and society. The primary endpoint was the rate of stage 2 or higher cancers. They had to be non-inferior, and this meant less than 1 additional stage 2B cancer for every 2,000 women screened. And the rate of biopsies was used as our morbidity assessment. And here are the results. This was a pragmatic, here's the consort diagram. There were 71,000 women who were randomized. Importantly, women learned about the study online. They could do it from their phone, their computer, any electronic device. They registered online. They were invited to choose randomized or observational. And at that point, they signed a consent online and then were randomized. 61% agreed to be randomized. Of the women who chose not to randomize and join the observational arm, 89% chose risk-based regardless of age and regardless of geography. The randomized cohort results showed we had 28,000 women in the randomized cohort. There were 14,000 women in the risk-based and the annual screening arm. You can see the distribution here that 2% were in the highest risk group, 8% in the elevated risk group, 62% in the average risk group, and 26% in the lowest risk group on the randomized side. Participants came from all 50 states. It's open across the United States. You can see the larger dots show you where our study sites were. Our demographics improved very significantly over time, improving the African-American enrollment from up to 17% by the end of the study, as well as 12% for the Latino women. The number of the cancers in each of the arms was the same, 263 versus 260, but they were very stratified by the patient's risk. And here you can see the highest risk had the most cancers, elevated had the next risk, the average, and the lowest, and here you see the annual group in comparison. Wisdom met the primary endpoint for safety. It was nowhere near the non-inferiority border, and in fact, just barely crossed the line for superiority. Here you see the cumulative incidence of stage 2B cancers on the left. But very importantly, the risk distribution is very interesting. In the women in the highest risk group screening every 6 months, there were no stage 2B or higher cancers, and followed by the highest number in the elevated, then the average, then the lowest, and then you see the average from the annual group. The radiologists in particular were concerned that we would increase the rate of stage 2A cancers as well, but we did not. You can see again, numerically, this is lower as well, and here this is stratified by highest, elevated, average, and lowest, and there's your comparison for the annual arm. One of the criticisms leveled at screening has been that there has been a very large increase in the number of early stage cancers without a concomitant drop in later stage disease. In contrast, when we look at the results from Wisdom, what we see is a stage shift where we have an increase in the stage 1 cancers, but a concomitant drop in the stage 2 or higher cancers. And here you can see this. This is the annual group. Watch the blue numbers go up and the red go down. So the biopsies were similar in both groups, but also stratified very much by risk. Same thing for the mammograms. The mammograms were fewer in the risk-based arm, showing less morbidity. But I think the distribution here actually helps us understand why we did not see a bigger drop in the biopsies and a bigger drop in the mammograms, is that, of course, people were not necessarily so adherent to their recommendations. You can see that the annual arm screened less often, and the average risk people who were supposed to screen every 2 years screened a little more often, as their numbers are close together. Population germline testing that was done in this trial showed that it was feasible. 77% completed their genetic testing. These are spit kits sent to people's homes. 3.1% of participants had pathogenic mutations. 1.2% were in the high penetrance mutations. Importantly, in both of these groups, fully 30% did not have any family history on their reports. That actually is going to be presented today by Fergus Kirkpatrick at Stars at Night 1 and 2. The uptake of preventive intervention certainly increased in the highest risk group. We have room to go. That could be better, but importantly, many of the women that we followed said they made lifestyle changes, which is good. The limitations are that not everyone followed their risk assignments. Now, we know that recommendations for screening come from many places, including annual recommendations from mammography centers. And we hope that the results of the Wisdom study will provide confidence that in future studies, including our ongoing platform of risk-based screening, that they can follow guidance safely. The pragmatic design required that this was all self-report. Importantly, 95% of all the cancers were able to be verified with imaging and pathology reports. We did registry linkages, and we did a deep dive at several of the centers and did not find additional cancers that were not reported, which is remarkable. The number of biopsies we have confidence in because they were about 4 times higher than the number of cancers. The expected cancer to biopsy ratio in this country is 25%. So I think that's remarkable that the self-report was as good as it was. Now you may ask, can we afford new approaches? Well, fortunately, it turns out that concentrating more resources on those at highest risk is very cost effective. And here, it's important to know that we spend an aggregate around $12 to $13 billion, but that's with a B, on screening every year. Now, depending on which guidelines you might follow today, American College of Radiology, which recommends MRI or supplemental screening for people who have dense breast tissue, that could range from $30 billion to about $8 billion for the U.S. Preventive Task Force. Fortunately, the risk-based arm comes in at about 7 billion. This is actually, I think, really important because this also reflects screening burden. But this is important. This is not just, oh, you get it, that we are not taking people who have a 20% lifetime risk and recommending that they have an MRI. We only did this for 2% of patients. So this poster is online, and you can see this. This was looking at these models. So what would the impact be? So as you can see, this is looking at the log hazards of mortality. And one of the reasons we picked the stage 2B endpoint is that's where there was a sharp demarcation in the log hazards of death. So if there are about 46,000 stage 2B cancers, converting 1/3 of them to less than stage 2A or equal to stage 2A has the potential to result in 4,000 to 5,000 fewer deaths at a lower projected cost and at lower screening burden for those at lower risk, which is about 54 of the 60 million women of screening age, including probably 1/3 of those who don't need screening till age 50. So on the basis of this, our team recommends that risk-based screening should become the new standard of care, but I think we have to make sure that we scale this with real fidelity so that we do it properly. And really, we should have a national screening program so that we can track results and do better. More for those that need it, less for those that don't. Smarter screening, not more screening, is the answer. Now, Wisdom is a platform trial. I think that all trials should work on continuous improvement. Wisdom 2.0 is underway. We already have 30,000 women enrolled. We are now refining the risk algorithms to predict fast and slow growing cancers using low-pass whole genome so that we can adjust, add new PRSs and adjust for ancestry, and hopefully next year we'll have Memo AI as part of this, and want to focus more on prevention. Importantly, we've lowered the risk assessment to age of 30 because finding these high-risk penetrance mutations is important in 30-year-olds, and we know that family history is not the way to find these people. And so here is the summary. The conclusion is that risk-based screening, including population genetic testing, safely stratifies risk and screening intensity. I think with better fidelity, we will see morbidity go down, both biopsies and mammograms. I want to thank all of the authors, all of our fundings, PCORI and the NCI, Breast Cancer Research Foundation, Quantum Leap, Safeway, Salesforce, so many, the VA, so many people made such a difference here, and many important individuals. It really takes a village. There are hundreds of people who worked on this study, and we want to thank especially all of the Wisdom Study participants who filled out their surveys and answered us, and any of you in the room who are in the Wisdom Study, if you haven't answered your surveys, now's a good time to turn it in. Okay, and I'm happy to report that I just checked. JAMA has published this online. It is free for everyone at the conference during the time of the conference, and I'll take some questions.
Thank you, Dr. Esserman. Outstanding work and very exciting. I'm seeing if we have questions. We do at microphone 2.
Eric Weiner, Yale. I don't have a question. I just want to say this is the most important thing we've heard at this conference. This is absolutely great, and I agree with you 100% that this should be the new standard.
Thank you very much, Eric. All right, who's going to work with me on making sure we institute a national screening policy so we can track outcomes and continue to make things better? Everyone, hands up.
Excellent. Microphone 6, I think.
John Benson, the United Kingdom. Clearly screening has always been a very emotive topic, especially here in the United States, and in particular for women aged between 40 and 50. So I'd like to ask you, Dr. Esserman, do you anticipate any, potential problems in a stratified screening program with those women at lower risk, being happy to accept that they may need less frequent screening?
Well, that is an excellent question. So 70% of the women under the age of 50 were told that they did not need to screen at this time. I think that you could see that the mammogram rates were quite a bit lower, but not zero. And that group, we have work to do. And again, There is a drumbeat of telling people that they all have to get screening. That has got to stop. We all have to work with our organizations to drive better response. The sister study, the MyPEB study in Europe, will report out at the beginning of 2027. We will be pooling our results. Their lowest risk group, they recommended screening every 4 years. They're also having trouble getting people to be as adherent. But this is a big sociologic change.
Yeah.
And we all have to work towards this. I think the bias amongst oncologists and breast cancer, people who treat breast cancer is, wow, screening must be good, more is better. More isn't better. More is just more. Smarter is better. And we also have to be on the bandwagon to change this narrative, to make a change. It will take a village, all of us together. And I think having a continuous platform to learn and improve is really important, especially for something that costs so many billions of dollars.
Right. Thank you.
Outstanding, and thank you, Dr. Esserman. We'd now like to invite Dr. Kamal Jabari to speak about imlunestrant with or without abemaciclib in advance